Welcome to AZENT's Guideline Updates, episode G12, Hypertension. I'm Dr. Z, and across the microphone is KC, one of our internal medicine residents who is spending this block in the outpatient clinic.
I am, and clinic is where blood pressure actually lives. So when I saw there was a brand new 2025 hypertension guideline from the American College of Cardiology and the American Heart Association, my first question was simple. Did the numbers change?
The targets did not change, and that is reassuring. The goal is still less than 130/80 for most adults. What changed is how we get there, how we estimate risk, and how aggressively we start. This is the first full rewrite since 2017.
So the threshold for calling it hypertension is the same?
Same staging. Elevated is 120 to 129 systolic. Stage 1 is 130 to 139/80 to 89. Stage 2 is 140/90 or higher. The categories are familiar. The action behind them is what got sharper.
Start with risk, because you said that changed.
The biggest single change. We now use the PREVENT calculator, which stands for Predicting Risk of Cardiovascular Disease Events, to estimate risk. It replaces the older Pooled Cohort Equations.
Why replace them?
Two reasons. First, PREVENT is built on a more contemporary and diverse population, so the estimates fit today's patients better. Second, and this matters, PREVENT is race-free. The old equations used race as an input variable, which never made biological sense. The new approach removes race from the calculation entirely and instead can incorporate kidney function and metabolic factors.
So when I am deciding whether a stage 1 patient needs a drug versus lifestyle, PREVENT is the tool.
Exactly. For stage 1, 130 to 139/80 to 89, you estimate 10-year cardiovascular risk. If the risk is high, generally 10% or more, you start medication along with lifestyle. If it is low, you treat with lifestyle and reassess. That risk-based fork is the heart of outpatient hypertension.
What about stage 2, the 140/90 and up patients?
Here is a practical shift. For stage 2, the guideline supports starting with 2 drugs, often as a single pill combination, rather than 1 drug at a time. Starting with a fixed-dose combination gets patients to goal faster and improves adherence because it is 1 pill instead of 2.
And which drugs are first line?
The same 4 proven classes: thiazide or thiazide-type diuretics, calcium channel blockers, ACE inhibitors, and angiotensin receptor blockers. And notably, first-line selection is now race-neutral. We no longer steer drug choice by a patient's race. We choose based on comorbidities, tolerability, and response.
Beta blockers are not first line then.
Not for uncomplicated hypertension. They stay first line when there is a compelling indication like heart failure with reduced ejection fraction, prior myocardial infarction, or certain arrhythmias. For plain high blood pressure, reach for the other 4.
What about the patient who is on 3 drugs and still not at goal?
That is resistant hypertension, and the 2025 guideline raises the profile of primary aldosteronism. There is now a Class 1 recommendation to screen for it in resistant hypertension using the aldosterone-to-renin ratio.
I always thought of primary aldosteronism as rare.
It is far more common than we used to teach, especially in resistant cases, and it is treatable, sometimes curable. So in the patient on 3 agents, including a diuretic who is still above goal, check that ratio before you assume it is just stubborn essential hypertension. And the guideline broadens consideration of screening even in some stage 2 patients.
And if the workup is negative, what is the next add-on?
A mineralocorticoid receptor antagonist like spironolactone is the evidence-based 4th agent for resistant hypertension, which the Pathway 2 trial supported. So the aldosterone story runs through both the diagnosis and the treatment.
Did lifestyle guidance change?
is reinforced. Sodium reduction. The heart-healthy dietary pattern, potassium-rich foods, unless kidney disease or certain drugs make that unsafe, physical activity, weight management, and limiting alcohol. None of that is new, but it remains the foundation under every medication decision.
And measurement? I feel like half my clinic blood pressures are garbage because the rooming is rushed.
You are not wrong, and the guideline is emphatic about proper technique and about out-of-office measurement. Home blood pressure monitoring and ambulatory monitoring confirm the diagnosis and catch white coat and masked hypertension. A single rushed cuff in a busy hallway is not how you should be diagnosing a lifelong condition.
Is there anything new on cognitive outcomes?
The guideline highlights that controlling blood pressure helps reduce the risk of cognitive decline and dementia, drawing on trial evidence. It is a useful motivator for patients who are not moved by cardiovascular numbers alone.
Anything for pregnancy since I see young women in clinic?
Yes, the guideline reflects a lower threshold for treating chronic hypertension in pregnancy and recommends low-dose aspirin in those at high risk for preeclampsia. The safe antihypertensives in pregnancy remain labetalol, nifedipine, and methyldopa, and you avoid ACE inhibitors and angiotensin receptor blockers.
And older adults? I worry about overshooting and causing falls.
Reasonable worry. The target of less than 130/80 still applies to most ambulatory older adults, supported by trials like SPRINT, but you individualize for frailty, orthostatic symptoms, and life expectancy. Treat the patient, not just the number.
Let me try to land this. Same target, less than 130/80. New risk tool, prevent, and it is race-free. For stage 1, use risk to decide on a drug. For stage 2, start with 2 drugs, often a single pill. First-line therapy is race-neutral, the same 4 classes. Screen-resistant hypertension for primary aldosteronism with the aldosterone-to-renin ratio, and use spironolactone as the 4th agent. Confirm with home or ambulatory readings.
That is the whole episode in one breath. The 2025 guideline did not move the goalposts. It modernized how we estimate risk, removed race from the math, pushed earlier combination therapy, and reminded us to look for the secondary cause we keep missing.
Better risk, better measurement, earlier control.
Well said. This episode is educational only. Thanks for listening to AZIN's Guideline Updates.